Yes. So right now, you and I can speak, and the audience can listen to us. We do have the hospital grand round teams on. So there's 4 hospitals. They're having their grand rounds, and we have a number of listeners on. The video is being recorded, will become part of the learning management system. However, the chat box is not going to be recorded. So we'll start. So a lot of the users on for right now already have access to the learning management system, so they know how this works. But what today's topic is our update for diabetes. And as you already know, over the last 1 year, we've done a lot of the topics that have a clinical and a regulatory review. Today's session, we have an endocrinologist, Dr. Sharma, who practices in Ohio, and she'll be talking about the clinical updates, and then I'll follow it up with the regulatory updates. Like all of you know, there's a disclaimer. We don't own the CPT, and that belongs to the AMA. The interqual, the level of care criteria that we'll be referring to, is part of McKesson. And a lot of you will receive links to the learning management system. This will be posted by the end of the day, as well as the PowerPoint slides. A lot of the slides on this already have links to the articles that we'll be referring to. So without taking more of your time, Dr. Sharma, would you like to briefly introduce yourself, and then you can tell me when you want the slide moved on to the next, and I'll take care of that.
All right. Well, thank you, Dr. Pahuja. As he said in his introduction, I'm a clinical general endocrinologist in Dublin, Ohio. A little bit on my background. I'm originally from India, and I did my residency here in Columbus and then my fellowship from Case Western. And I've been in practice since 2010. I do general clinical endocrinology, like I said, and a bulk of that is diabetes, especially type 2 diabetes. So I will be trying to give you some idea of the clinical updates and their relevance in today's world, and then Dr. Pahuja can tie it to the regulatory updates that he has for you. If we can move on to the next slide.
Okay. So I think what one thing Dr. Sharma didn't mention is she is my senior from med school, so I did rotate for 2 sessions under her. I'm not sure if she remembers that, but I do. All right, so just the objectives that we want to talk in during this 45 minutes is newer strategies for diabetes management, newer drugs, insulins, glucose monitoring systems, and then I'll talk about spectrum of auditors, what's going on diabetes from Congress, FDA, CMS, and then the ICD-10 changes. So I'll start off with your slide, Dr. Sharma.
Thanks. So, right off the bat, as regards the clinical update, we all know there are several medications and several strategies out there in the market now that are being used. But to go back to the basics, why do we need these new strategies for diabetes control? And the real idea is basically we want strategies that allow us to give tight control of blood sugars without any hypoglycemia. And these 2 things came around from the DCCT trial on people with type 1 diabetes and the UKPDS trial on type 2 diabetes, which established that diet control eliminates or reduces microvascular complications by more than 50 to 70%. So that's a huge reduction, and that's where in the 90s the strategy of diet control came about. We all know that led to significant hypoglycemia increase, and so this need for strategies that wouldn't cause hypoglycemia but allow diet control started. So that push started not that long ago, maybe 15, 20 years ago. So then the diabetes regimens did become complicated. So now we want regimens that are easier to use and titrations that are easier to follow. We all know those increase patient compliance. There is an inherent problem with medications that were available then and are still available, which is a certain doses of insulin and sulfonylureas that do cause some weight gain. So we want medications that don't do those. And then while we are at it in trying to lower blood sugars and make them tighter and tighter, we certainly want sensitive monitoring to go hand in hand with it. So all these slides that I'm going to show you are directed towards achieving these goals. Next slide, please. The newer approaches of diabetes management, they can broadly be divided into biological and technological developments, and I'll tell you how these are divided. These biological developments, I'm categorizing medications into those. There are several developments in the last 10 years, especially in the last 5 years. The biological medication classes that have come about in combination are called incretin mimetics. The GLP-1 analogs, a lot of us know them as brand names and pharmaceutical names, as well as DPP-4 inhibitors, again, branded names or the pharmaceutical names combined known as gliptins, the SGLT2 inhibitors, and then the insulins. The technological developments are in glucose sensing mechanisms or continuous glucose monitoring systems, and then insulin delivery systems, which are insulin pumps and hybrid closed loop systems. Next slide, please. So I'll quickly give you an overview of these one by one. So incretin mimetics, they are broadly divided into two categories, GLP-1 agonists and DPP-4 inhibitors. That's at the bottom. But if you look at the top of the slide, they are both targeting GLP-1 deficiency in people with type 2 diabetes. This GLP-1 neurotransmitter / hormone, it allows glucose-mediated insulin release and glucagon inhibition. And when you supplement the GLP deficiency with these medications, the whole metabolism of glucose improves. The nice thing is, since these agents are glucose dependent, you really don't see any hypoglycemia with them, because as the glucose levels fall, the insulin and glucagon adjust accordingly. The agonists, they're all injectables. They increase GLP-1 levels. We commonly know them as exenatide and the natides. I'll show you the names in the next slide. And then the DPP-4 inhibitors, they are tablets. They decrease endogenous GLP-1 breakdown. So if you could move on to the next slide. GLP-1 analogs, they are adjuncts for uncontrolled type 2 diabetes. They are not to be used with type 1 diabetes. They are not FDA approved for type 1 diabetes. They commonly cause nausea, although the newer preparations are better. They are, to some extent, weight losing, though GLP-1 analogs for diabetes are not recommended as therapy for weight loss or obesity. They are recommended for glycemic control, and they are all injectable. Next, please. The DPP-4 inhibitors, similar to the GLP-1 analogs, they are adjuncts for type 2 diabetes, not approved for type 1 diabetes. They don't cause any nausea, usually minimal nausea, if any. The weight loss, they're pretty weight neutral. They don't cause weight loss or weight gain. They're oral medications, and they're slightly weaker than the GLP-1 agonists. So to give you an idea, the DPP-4 inhibitors, they reduce A1C by about 0.5, and the GLP-1 analogs up to about 1% or a little bit more. Next one, please. So here's the comparison between insulin and the incretin mimetics. These were one of the first classes of agents that sort of, they were injectables other than insulin. So a lot of comparisons happened between these at the time. On the left, you see insulin is an injection. It causes weight gain. It has a propensity to cause hypoglycemia if used injudiciously. It doesn't cause any nausea, but yes, its efficacy is endless. You can use it endlessly. We all know that. GLP-1 agonists, they are also injections. They do not cause weight gain, so that's an advantage over insulin. They do not cause hypoglycemia, which is also a big advantage over insulin. They cause some nausea, usually that is surmountable, but their efficacy is pretty good. It's not endless, but it's quite good. DPP-4 inhibitors compared to both of these, they're simple to use. They're not injections. They don't cause weight gain. They don't cause hypoglycemia. They don't cause nausea. But their efficacy is very moderate compared to these two agents. Next, please. So these are the names that you all may be familiar with. The GLP-1 agonists, exenatide, liraglutide, the extended-release exenatide, albiglutide, dulaglutide, lixasenatide, and actually there is another one since this slide got made. It's a combination of liraglutide and detamir being released as Zoltrophy by Novo Nordisk shortly, within the next few weeks. And then the DPP-4 inhibitors, we all again know these names: sitagliptin, saxagliptin, linagliptin, alogliptin. They're all fairly similar to each other. You would notice a barrage of medications that have gotten approved in the last 5 years. One little piece in GLP-1 agonists, the newer agents like Bydureon, Tanzium, Trulicity, these are the trade names. These are once-a-week injections. So this problem of frequent injections, they're trying to surmount that by extending the half-life of all these agents or their duration of action. So this is as far as this category of medications is concerned that's out on the market. Next slide, please. The next category that we have are SGLT2 inhibitors. These are oral agents. They reduce renal reabsorption of glucose, and what is not written here is this action is insulin independent. So irrespective of the body status of insulin, these SGLT2 inhibitors will do whatever they need to do based on glucose levels in the body. So their action is glucose dependent, but not insulin dependent. The possible side effects, majority of them are all related to the glycosuria that these agents induce and the osmotic diuresis these agents induce because of the glycosuria. So people can have urogenital infections, they can have nocturia, in severe cases they can have intravascular volume depletion and cystitis. So these are very effective agents. Most of the side effects can be bypassed or reduced when they are used judiciously in the right environment. And one of the examples would be that you want to use these agents when their average blood sugars are at least somewhat below 250 or 220, so you don't induce brisk diuresis and brisk glycosuria. Very effective agents, and they're oral. Next slide, please. As I said, all these agents in the United States have been approved within the last 5 years. 2013, canagliflozin was introduced, 2014, dapagliflozin, and then later that year, empagliflozin. A little caveat over here, all these agents, again, are very similar in their action. There are slight differences in the GFR at which they are not recommended. And a new emerging change is some studies have showed that empagliflozin, for some reason, reduces cardiac death. We don't really know the mechanism of that, and nobody right now is sure that it is doing that as a class effect. So that is that drama is unfolding right now, and it may influence how guidelines change about placing where it needs to be used. But right now, all these three agents are used interchangeably for diabetes management in people with type 2 diabetes, not approved in type 1. Next slide, please. Some of the newer insulins that I just wanted to mention, there is a new inhaled insulin on the market called Afrezza. This is a short-acting insulin approved for prandial use in people with type 1 or type 2 diabetes. If anybody remembers the days of an agent called Exubera, this in one way is an improvement on that, in that the inhaler is actually very easy to use and easy to carry. The Exubera inhaler used to be very, very cumbersome, and the dosing used to be very cumbersome. The limitations of Afrezza are similar to any inhaled agent that has dose-dependent sensitivity. We need to to make sure that the absorption is okay. So baseline FEV1 testing is required, and it may be required often for a lot of these people, and that is one big limitation to its use. There are post-marketing studies in progress regarding use in people with baseline lung disease and whether exposure to the lung tissue increases lung cancer risk and what have you. This insulin is on the market to be used as an inhaled agent, so it is a change. Insulin degludec is marketed as Tresiba, manufactured by Novo Nordisk. It is a new compound compared to Glargine, which was initially sold as Lantus, and Detamir, which all these years has been sold as Levemir. So this is a third agent by the name of degludec. It has a very long half-life, but its steady state is reached if it is injected every 24 hours. So it is still dosed daily. In trials, it has been shown to cause less hypoglycemia compared to Glargine, and that's how it is used as a basal insulin. The other insulin that is out on the market is concentrated Glargine, which is marketed as Toujeo. So the molecule is still the Glargine molecule. It is just concentrated and packaged differently. Otherwise, the agent is the same. There are some claims that it causes better diabetes control or gets better results than non-concentrated Glargine. We, in the active practical environment, we tend to often use these agents when the dosing is large. The actual pharmaceutical difference in clinical practice, it varies from physician to physician. So these things are out there for use. Next slide. Moving on to glucose sensors. I hope the speed is okay for everybody. I'm not rushing through anything.
I think you're doing great, Dr. Sharma.
All right, thank you. So let's move on to glucose sensors. We talked about the agents that are out there currently, but what about glucose monitoring? When you're trying for very delicate diabetes control, you want to be able to sense that you're doing that. So look at how far we have come. It started off with self-monitoring of glycosuria. That was in the 70s and prior, where one would basically use these strips to measure, with color change, to measure glucose in the urine. It was very inaccurate, but it was easy to do. That moved on to self-monitoring of blood glucose, capillary glucose, which we commonly call AccuChecks or capillary blood glucose measurements. These, as we all know, these are intermittent and patient-driven. The patient has to be invested in checking these blood sugars from time to time. But it's intermittent. It's like a snapshot that you take 3 or 4 times a day to understand what the trends actually may be. The continuous glucose monitoring systems, they have gone through a lot of change and evolvement over the past, I'd say, 6 to 10 years. Their insurance coverage has improved. Their acceptance has improved. Their applications have been evolving over all these years. These monitors, they basically they sense sugars in the body fluids nearly continuously, every few minutes, to a large extent without patient participation. So they are continuous, they are automated. The patient is involved in using the device, inserting and changing the device, and calibrating the device with his own blood sugars, but the rest of it is being done by these systems on their own. A good feature is that they can alert, they can have vibrate and audio alerts for severely high and low blood sugars. They allow for pattern identification for the patients as well as us as clinicians. And lately, they are being used to allow control of insulin delivery systems or controlling the insulin pumps based on what somebody's sugars are. So very rapidly evolving technology with variable applications. It was originally designed just as hypoglycemic alerts for people who cannot feel their low blood sugars, but it has evolved since then. And I'll show you a slide as to how useful it can be. Next slide, please. So these CGMs, these fluid for glucose measurements. The sensor is a little filament that is inserted subcutaneously, so that it's resting in the subcutaneous fluid, and that is where it is measuring the glucose. And because it's not a direct serum VG measurement, you do need those calibrations for these monitors right now. So the patient will check their own blood sugars, and the sensor is going to calibrate it accordingly, and extrapolate those results. There is something called a sensor lag, where once the sensor is placed, these sensors can be changed every 6 to 10 days. So a new sensor inserted every 6 to 10 days, it has a little bit of a sensor lag of a few hours. You cannot instantly rely on these systems when you change them, and the patients are to be aware of that. They have something called a warm-up time, similarly, that they cannot be used right away for the sensing, and whatever they are detecting in the interstitial fluid it's lagging behind whatever is happening in the blood at that moment. So blood sugars are falling, for example, extremely rapidly. The sensor may not be able to detect that speed with that accuracy. It's something to keep in mind. The patients it's a device that needs to be inserted subcutaneously, and they have to change it every few days. So yes, they have to change those sites. There is frequent and such site change involved. And accuracy and precision is always, a lot of these companies are in competition about, and then we as clinicians are always careful about and warning patients about that. Since it's a somewhat indirect measurement of serum glucose, one should be checking their sugars if in doubt at any time, and any good device that is approved by the FDA has to fall into a certain range of accuracy for it to be a reliable measure of serum glucose, or a reliable estimator of serum glucose, I should say. Next slide. These are the three companies in the market right now in the United States that manufacture these monitoring systems. So Medtronic is well known for devices, not just for diabetes, but for several other specialties. They make a standalone sensor. They also have a sensor that can be used in combination with an insulin pump. And their newest device, called the Medtronic 670G insulin pump, it's a hybrid closed-loop system which utilizes a continuous glucose monitor to control insulin delivery. I'll talk about that separately, briefly. The next one is Dexcom. It only comes as a standalone sensor. It has loose combinations with some other pumps in the market, simply to share the reader screen, but it does not control those devices. And then it does have the capability of the readouts and the graphs and everything being available to view on smartphones for people. So one less device for people to carry. The Freestyle Libre, that's the newest device that has been approved in this category in the United States. In USA, it's only available for professional use. In Europe, there is one which is available for personal use as well, similar to Dexcom and Medtronic. The Libre allows for monitoring of glycemic patterns by us as clinicians in routine practice, and it's very popular. Next slide, please. This is a Libre download, so I'll walk you through this slide. I hope it's clear to everybody. So on the top left, this is a patient. This is a real slide from a real patient. The top left is the patient's blood sugars. This is his glucometer download. We routinely download glucometers in the office. So this is his glucometer download. I don't know if you can read the numbers, but I will tell you the green numbers, the greens are usually, they are 90s, 106, 104, 92, 82. That is the range of those numbers. The reds are about 160 to 180. So you see, this man is checking his blood sugars 3 times a day. On the left, the horizontal is 1 day. So this man is checking his blood sugars 3 times a day. And majority of these blood sugars are in the ranges of low 100s to the 90s even. And what happened with him was his A1C was about 8%. I forget now, it was about 7.9 or 8%. So on the face of it, it's not a horrific A1C. His A1C, it's not like 11 or 10. But these kind of numbers, 106 and 90, they don't match an A1C of 8. An A1C of 8 is an average blood sugar of about 180. So there is a clear mismatch over here. You could think that he has hidden high blood sugar somewhere. You could think that the A1C is incorrect. You could think that the glucometer is incorrect, or a little bit of all of the three. So there was this mismatch, and therefore he was placed on the Freestyle Libre in this instance. Any of the monitors can be used. In this instance, this is what the Freestyle downloads look like. They're all very similar. So if you go to the picture, the next picture on the left, this one where the arrow is. This is a composite of the 10, 12 days that the patient wore that monitor for. Each color here is a day. On the left is basically midnight, and then 2-hour intervals that goes on to the right. As you move across, these are 2-hour intervals. And then as you move down, these on the left are blood sugars, 300 at the top, or 350 at the top, 300, 200, like that. So already you can see there's a lot, it's not a nice flat line. All these lines are running into each other, going up, going down. And if you move on to the right, the next, on the right, next set of graphs, now where his arrow is, these are daily breakdowns. This is very informative for patients as well as us, because we notice here, again, the bars and up and down is the same across our time of the day, and up to down is blood sugars. But each graph here is 1 day. So on day 1, blood sugars at night. This is midnight where his arrow is right now, and then it moves across. See, blood sugars are dropping between 80 to 140. And then the yellow is blood sugars that are all over 140. In fact, they're peaking into the 200 and 300s even. So they're running pretty high all day. He probably manages to catch those sugars at a time when they're a little closer to the 140s. If you move on to the next day, same thing is happening. Blood sugars are much lower at night, and in the morning, if I were to able to combine those times, these are times this man is eating. So his blood sugars are jumping exceedingly high after meals, and the peaks are not always sustained, so he manages to catch the next blood sugar, which again looks better. Each day is like that, and so it is very visual for the patients as well as us that, okay, these blood sugars are clearly, they are not constantly high, the meter is not wrong, nothing is wrong. He is truly having fantastic postprandial hyperglycemia, and it is safe to adjust his medication regimen, dig a little bit more into what he's eating, and try and make sure that he can actually match his medications to his eating better. These are very, very informative devices, and they are very visual for the patient. The graph at the bottom, where Dr. Pahuja's arrow is right now, this is, again, it's a different composite, and the blue line is basically just giving you the overall pattern, which is lower blood sugars at night, hovering in the 80 to 140 range, which basically peak every time the patients eat. Next slide, please. Insulin pumps, they are fancy ways of giving insulin because you can adjust insulin rates. They have variable basal rates that we can adjust. Patients have to think a little less when they are giving themselves insulin boluses because the calculator or the bolus wizard is in the device, and fewer needle sticks because these devices will allow you to take insulin through the push of a button for up to 3 days before they need to be changed. Happy devices when used intelligently. Next slide, please. Finally, the hybrid flow system, one quick word for it. There is an insulin pump for insulin delivery. Right now, it's the Medtronic insulin pump. There is a glucose monitor for glucose measurements. I just showed you one of them. This one is the Medtronic glucose monitor. And there is a built-in glucose to insulin algorithm that is inside the insulin pump. Something similar to the IV insulin drip protocols that a lot of doctors and nurses follow in the hospitals, just that it is translated into a subcutaneous system where we are relying on glucose monitors to control insulin delivery. There is an auto mode insulin delivery based on glucose levels and changes, so that's the auto mode, but it also has the usual manual mode that we are used to where patients are checking their own blood sugars, I am programming how much insulin they should receive and all those things. This Medtronic 670G was approved in 2016 in the United States, and it is currently available for general use. There is a slight delay in when patients receive it, but yes, it is available. Next slide. I think I might be close to getting done. Yes, please. Dr. Pahuja?
Yeah,
so I think over to you.
Yeah, thanks, Dr. Sharma. There's a few questions that have come in. From the Grand Rounds team, I think one of the physicians is asking what happened to the old metformin and sulfonylureas once these new drugs have come in.
So they have not gone anywhere, and I think, Dr. Pahuja, there is a slide coming up in your deck that will explain how these medications have changed in their usage percentage over time.
Yes.
But just for everybody, the treatment algorithms, they still start with metformin for people with type 2 diabetes. Sulfonylurea is in the algorithm, but the algorithms are a little bit more liberal and we are talking about the ADA as well as the ACE algorithm for diabetes management. These, they leave it up to our discretion to decide where to place sulfonylureas. In clinical practice, I will tell you, a lot of us as endocrinologists, we do favor the agents that don't cause hypoglycemia and are weight friendly. So we do favor using metformin, incretin mimetics, the SGLT2 inhibitors, DZDs. We favor these agents over the sulfonylureas. Yes, there are insurance hoops that we have to jump over sometime where sulfonylurea use may need to be documented and so on and so forth. But as far as plain physiology is concerned, when you try and use all these agents in nice combinations, that's when you get the most sustained and best results.
Okay. And there are some other questions about continuous glucose monitoring devices, cost of the drugs. I think we should go with the regulatory slide deck because a lot of these questions that have come in, the answers are going to come in this slide deck. All right, so thanks friends and thanks Dr. Sharma for the clinical update. The regulatory update is a number of slides. I don't recommend that you make any notes on this. Just listen to what's going on, and the decks will be available through the learning management system. So when I started making this slide, we decided to do the updates a few months back, but just last month on April 13th, the NIH released this study about rates of newly diagnosed diabetes of type 1 and type 2 that was on the rise among children. And the key findings were that type 1 is increasing more in males, and among those a higher rate in Hispanic youth, while the ages 0 to 19, the incidence was increasing more in females. Now, Dr. Sharma, are you seeing the same trend in your practice also?
So actually, interesting you ask. I mainly practice adult endocrinology. So this age group, honestly, I don't see a whole lot of, but
okay. And I think a lot of
the trend in the adult population. Let me put it that way.
Okay, and I think the group knows I'm both medicine and pediatrics. So the rate of rise is actually proportional to the incidence of obesity that we're seeing. A lot of the kids in the ages of 8, 9, and 10, with their BMIs being more than what they should be, I think the obesity, the incidence of diabetes, and dietary issues, along with lack of activity, and that branches into a whole new topic about how much activity and exercise should kids have. But I'm not surprised by the numbers that are showing up. The worry part is, when there is an increase of type 1 and type 2, it just means that the effect on society and the cost to the society with these diseases, with life expectancy being in the 70s and 80s, that's where regulatory updates are coming in, and I think that will be followed in some other slides that we see. So there are a lot of NIH-funded studies that are happening. The Diabetes TrialNet, the environmental determinants of diabetes, and then the Today study, or the treatment options for type 2 in adolescent and youth. And again, just clicking on this will take you to the study, and it will open up the whole study in a new browser. Now, this is something that we had a question while you were talking about the newer drugs, the dramatic shift in drug utilization. And I think when we were preparing the slide deck, Dr. Sharma and myself, we were talking on what happens to the older drugs. And as you can see, from 2006 to 2013, there were increases in the use of metformin from 47 to 53%. This sharp increase, and I know, Dr. Sharma, you had a comment on why a 0.5% increase to 15% for DPP-4 inhibitors.
Well, actually, so this bullet and the next bullet that you have on there, I have a comment on that, in the sense that the DPP-4 inhibitors came into the market around this time. The GLP-1 analogs and DPP-4 inhibitors came into the market at this time. Imagine you have a new agent to use that does not cause low blood sugars, and it's a daily pill. Causes no nausea, causes no load. People would latch onto it whether or not it's going to make their blood sugars better. It was used freely, very freely. So that is where the DPP-4 inhibitors come in. The GLP-1 agonists, their increase is not that dramatic, partly because they are injectable, and the newer agents, the ones that were easier to use, they came around 2010, 2011. The first agent that was marketed was exenatide, which was Byetta. It was difficult and cumbersome to use. It was still a twice-a-day injection, and this is data from 2006 to 2013. So you can imagine that. And then there's some increase in insulin, so fine. People are a little more cognizant of using basal insulin instead of sliding scales. So that's that. Okay. And then in your next bullet, you have declines in the use of sulfonylurea. So that was what my comment previously was. And then TZDs declined. I had a comment on that when we were going over these slides, if you remember, Dr. Pooja. Yeah. They came, this sharp decline in TZDs was because of the paper that came out, meta-analysis, I should say, that came out regarding Avandia and all the risks associated with it, so much so that the drug died. And these agents, because of all the worry that they have generated in the minds of people, their use has gone down. So all this data makes sense. We have seen that in clinical practice.
Okay, all right. And I think you mentioned this is only till 2013. So when the latest set of data comes out, and this was from 1.6 million people. And then the study, when you look at it, has this age range, but with the growing incidence of the younger population getting diabetes, trying out newer drug therapies, these numbers may change over the next few years.
Yes.
All right. So while we were finalizing this slide deck, there was an announcement from the Rural Health Policy, the federal office, on 28th. So just last week. So we have all these new drugs coming out. We have the older drugs. We think we have continuous glucose monitoring. But what they found out is 62% of non-metropolitan counties did not have basic diabetes self-management education. Now you have to realize, of all the hospitals in the country, half of them are rural. However, they only take care of 1/6 of the population. And that even equates to about 50 million people. But rural hospitals not even having basic preventive care and self-management, that's where I think the focus is on expanding this sort of education. And I know there are some hospitals in rural counties that are part of the LMS. But I think what they're not struggling with is new technology. What they are struggling with is how do we get existing basic grassroots technology out to the population. But this was, clicking on it should take you to the full policy statement. Now coming back to where does all this tie up? So CMS, people know that with 2017 there are new payment-based systems. So there's the APMs from the MACRA and MIPS, and CMS has done a lot of effort in trying to educate based on what these sort of education is, and we'll talk specifically for diabetes. Just so that everyone knows that diabetes is one of the quality measures that's being looked at, and that will determine payment decreases or increases, right down to 4%, 5 to as high or low as 9%. So 2017 is base collection year for your primary care practices, and payments will start changing in 2019 onwards, and the max that could change is a 4% plus or minus. But what's important for diabetes is these primary care quality measures. So the individual provider quality measures, one is A1C less than 8%. And the basic requirement is more than 80% for Medicare Shared Savings Program. Now that ties up with LDL less than 100. Now when these quality measures were introduced, the new cholesterol management guidelines weren't in place, but CMS has stuck to requiring greater than 60% threshold for patients having an LDL less than 100. Same thing with blood pressure, tobacco use, and the one that is required for diabetes and vascular disease is greater than 90% should be on aspirin. So this is a slide where I know there are some case managers and directors of case management on this system as well as the LMS. Having your providers educated on what the quality measures is for specifically for diabetes, and this is what you're going to be measured on, and eventually this is what your payments will be based on in 2019. So we all know what CMS is coming out. Value-based care is the new buzzword. So there's MACRA, there's MIPS, there's APM, the next generation ACO models, comprehensive primary care plus programs, and eventually the chronic care management programs, of which diabetes is one of the highest ones just based on the incidence and the cost. When we look at spectrum of auditors, what you can see a traffic light pattern, the red, the orange, and the green. The greens are our friends. They keep telling us what we need to do in order to be compliant. So the certs and the QIOs. When we move on to the middle three, those are the compliance oversight. So when you hear about RAC audits, MIC audits, MAC payment updates, this is where they've identified whether you're in compliance with CMS's policy or not. And in case you're not, or there is an overpayment or fraud and abuse, that's when the top three, the DOJ, OIG, and ZPICS come in, and these are the organizations for legal oversight. Now, this is just from a government standpoint. Insurance companies, they themselves are sending notice of improper payments and recoupments, and how this pertains to us is, who gets qualified for continuous glucose monitoring systems. Right now, there's a huge uproar on whether that should be covered or not, and who's eligible for those. Aerolib has been doing auditing for many years, and what we're trying to look at is the common sense approach of, whatever you're documenting, whatever you're treating, is that reasonable? Is that medically necessary? Do they meet professionally recognized standards of care? And if you are providing them in the hospital or an inpatient or a skilled nursing facility, can they be done in an alternated setting? And so what is important from the provider's documentation standpoint is documenting what you are doing for patients with diabetes, whether it's an office visit or whether it's a consult or an admission, what the severity of illness is and what the intensity of service is. Now, why all this is coming about is because diabetes is a very expensive process, and the RAC program, it was a huge hit. They recovered $800 million a few years ago. They're actually recovering about $4 billion a year from hospital systems regarding underpayment or the lack of documentation. hospital basically wants to make sure there's consistency in what providers are doing. And so the idea is not to read the entire slide, but you might be being exposed to hospitals bringing in total quality management teams, Lean Sigma 6 teams, companies that can do data mining. But what pertains to diabetes is the fact that it's very costly, it's growing, and it's being diagnosed much younger, which is why there is a separate congressional caucus on diabetes. And they have spent a lot of time, energy, and effort. The bills that they have introduced so far is the Eliminating Disparities in Diabetes Prevention. Again, anyone who wants to read the bill can click on this when they get the slide deck. Protecting Access to Diabetes Supplies Act, the Medicare Continuous Glucose Monitoring Access Act, which gives some determinants on who should get the continuous glucose monitoring, and then the Preventing Diabetes, as well as the Access to Quality Diabetes Education. So far, all they've covered is what the new devices are, who are the target populations that are not getting basic care, who are not getting education. Congress is worried more on a population health perspective. A lot of the people know about LCDs and NCDs, and NCDs are national coverage determinants. So far in the endocrine chapter, they have diabetes outpatient self-management training, home blood glucose monitors, closed loop devices, insulin syringes, treatment of obesity, and then an outpatient IV insulin treatment. And again, clicking on this will take you to this page from CMS. When you open it up, you can see what sort of coverage determinants they have. One of the things that came up a few years back is what's new in the world of ICD-10 and diabetes. And a lot of us have been trained on ICD-9. With ICD-10, this was more, a specificity of documentation. But in terms of diabetes, it was a cause and effect relationship. So the word with and associated with, this becomes more important for ICD-10. So when we look at a case, patient with type 2 diabetes with infected ulcer of the right midfoot growing MRSA, with a past medical history of end-stage renal disease and polyneuropathy, ICD-10 will assume a causal relationship between the diabetes, between the foot ulcer, the polyneuropathy, and the chronic kidney disease. And thus, they can actually bill as type 2 diabetes with a foot ulcer as the principal diagnosis. But again, there is diabetic polyneuropathy, and then diabetes with diabetic chronic kidney disease. Now, what this does is, different from ICD-9 to ICD-10 is, it clubs your diabetes into what we call as HCCs, or hierarchical condition codes. And there's a separate presentation on the LMS exclusively just for HCCs, trying to understand what it is and how it makes a difference. One thing that ICD-10 was not able to do is it does not presume a linkage between diabetes and osteomyelitis, and that's understandable. Patients in a nursing home with diabetes and sacral decubiti, it's unless the provider writes that the decubiti and the osteo was a direct result of the diabetes, ICD-10 will not presume that linkage. ICD-9, however, did. One of the funny things in ICD-10 is they forgot to add the code for diabetic ketoacidosis. Now, it's being used in Europe. The system in US, the National Center for Health Statistics, has noticed this oversight, and that should be corrected end of this year or early next year. But for right now, DKA is coded as a E1310, which is other specified diabetes with ketoacidosis without comma. And I know this was one of the questions that we had received from the hospital Grand Round team. Now, there are some codes that are assigned for hypoglycemia, and like we all know, with coma or without coma. What's new with FDA? Now, FDA had released some updates regarding to diabetes. I think the one that was important was the December 20th, 2016 one, where it expanded the indications for continuous glucose monitoring systems, first to replace finger stick testing for diabetes treatment decisions. So the fact that FDA has expanded some of the indications, and those are found on this slide, and I'm not going to read this. I think with the team who has access to the video, you can pause and read some of the indications that FDA has allowed for continuous glucose monitoring. But like Dr. Sharma said, there are loops that you need to go through while you're requesting for this based on an individual patient basis. There are some ACE clinical practice guidelines, again with continuous glucose monitoring. A lot of the insurance companies have their CPT codes updated. And again, I think the disclaimer was very clear. It belongs to the AMA. We are basically using this for an education that there are a number of CPT codes for continuous glucose monitoring as well as insulin delivery systems. June 14, 2016, there was some drug safety warnings. Clicking on this will take you to those drug safety warnings for strengthened kidney warnings that FDA released. And being exposed to knowing what the FDA is doing helps you trying to establish what's right and wrong with your patient populations. Now, the FDA allows the public to go to their advisory committee meetings, and I've put up the link here for any one of you who's interested in the area. The last one for endocrinology was 28 June 2016. They give the address. Click on this calendar and see what's new, what's updated. Go ahead, see what Congress and what the FDA, there are a number of industries that are represented on these advisory committee meetings, but it's good to know the direction of what the administration is taking on diabetes. I think that's about it. Dr. Sharma, your comments?
I think that was a pretty thorough regulatory update, very pertinent and relevant. If anybody has any questions, clinical questions for me, I'll be happy to answer.
Okay. So they all have access to your email. Right now, one of the questions that has come up with is, how do you transition to newer insulins?
That is a very broad question, and I'm not sure if this is the right platform to answer it because of how non-specific the question is.
Sure.
What exactly is somebody pertaining to? Is it the concentration that is bothering somebody? If that is a question, that's a simple answer. The newer insulins are all, even though they may be concentrated, the injectable device, the pen, that takes care of it. So when you say 60 units, it is 60 units of whichever basal insulin you're injecting, whether it is Tresiba or Tresiba 100, U200, Toujeo, Lantus, they are all, the 60 means 60 on the pen.
Okay.
A lot of these newer insulins are not in vials for this reason.
And I think what you're saying is absolutely right. This whole platform was to give an update on what's new going on. This should not be regarded as clinical advice. I think with the newer insulins, they have their package inserts. If someone wants to reach you, they can email you with some specific questions. And again, friends, anytime you ask a question, make sure there is no protected health information, no patient information in that. Feel free to reach out to Dr. Sharma and then have that discussion. I think one of the people are asking about the LMS. I'll just do a quick few slides before we wrap up. So, going on to aerolib.com, once you have your user access and subscription email password, get onto the LMS login page. It should open up your learning page. It will list the topics that are there. You can, for example, in the acute kidney injury, clicking on it, enrolling on it, clicking on it will take you to a page that opens up the videos and the slide decks. And so just like the diabetes updates, the ones that we already have are the COPD, sepsis, pneumonia, CHF seizures, TIA, arrhythmias, and each topic talks about, some cases, the 2 midnight rule, what's the red flags and documentation. There are some topics that have been put in by national level speakers. There's an administrative law judge who's talking about the appeals process and what goes on when your case is being put forward to the administrative law judge. There's some mock hearings with retired Judge Bob Soltis. And then some new ones that have been put in is when you're actually appealing your case, what sort of inpatient decision template do you want, or a proposed decision template. And this is from the administrative law judge. So just some beautiful webinars that are on there. But I think that is the end from my side. We don't have more questions. Anyone who needs to reach us can email us, and that'll be the end. Dr. Sharma, thank you so much for your time today, and we're looking forward to getting some more updates in the next few months on diabetes from you.
Thank you, everybody. Thanks, Dr. Pahuja, for having me.